you're all doing good. Guys, welcoming you to the third session of OMR series. It's the last task which we'll be doing in labor and delivery. Hope this would add value to your preparation, because this is a very important task which we are going to do today. And remember, success is always what you enjoy doing. Preparing for the success is more fun than having pass or fail towards the end. So enjoy your success, love what you are doing, enjoy your process. So obviously the results default, it would be really awesome. So today we are going to talk about the structured discussions, like how to manage through one task, obviously, tips and tricks to manage the structured discussion and the communication, how you can keep it crisp or probably make it more beautiful by justifying. So as I always say, justification should be very minimal, and you have to make sure that it is not too less or too much, and how to organize the task. Okay, so we shall do the task first and then we shall discuss about the same. Aisha? Hi, Aisha. Thank you. Thank you so much for joining. Okay, let me keep the timer and then start the task. Okay. Hello, I'm Sowmya, one of the candidates for the exam. I have gone through the scenario and I'm happy to start the discussion.
Oh, hello, Sowmya. How are you doing today?
Yeah, thank you so much. And what about you?
Yeah, good. How do you summarize this case?
Okay, so as I understand that I am dealing with a primary gravida with a definitely delayed second stage of labor, and she has been a low risk pregnancy, and she has been like no other risk factors I can see here, and she's fully dilated since she's fully dilated and she has been pushing for the last 3 hours, and analgesia, she's on epidural. But I'm a little worried about the station. It is 1 centimeters above the spines, and thankfully, the CTG is fine. So I would definitely want to think of cesarean section in this case because of the higher station and also because of the caput and the molding, which is 3+ here, and with the good contractions as well. Yeah.
So can you elaborate how would you manage her?
Okay, yes. The first and most important thing is I would alert my consultant because I need to take his opinion. And definitely I would alert the pediatric neonatologist as well and the OT team and the anesthetist. I would discuss with the woman what are the pros and cons of having a cesarean section now. I would definitely talk to her about the need for the cesarean section as the station is very high and she's been pushing since last 3 hours and already she's on epidural. And also, I would review her notes for any allergies, reservations for the blood transfusion. I would check I'll have a quick look on blood investigations and also whether the group unsafe has been done or not. Apart from that, I would take a written and informed consent from Ms. McKinda, and then we would be shifting her to the theater. In the theater, the pre-procedure, couple of things which I would want to do. I would definitely want to check the fetal heart rate. And before we put the incision, we need to check the position and the station of the fetal head. And also we can think of manual displacing the head, and also fetal pillow was used before, but right now it is because of the conflict of the interest, it is taken away. So once everything we have decided and she's been catheterized and like she's on the table, WHO surgical safety checklist would be done, and then we would be starting with the procedure as such. So should I go ahead with the procedure?
Yes. Yes.
Okay. So the incision, the skin incision would be Joel Cohen's, because that is that is an incision which is recommended and it has a lower morbidity and lower rates of infection. So after that, I would be dissecting the rest of the layers blend. But once I open the peritoneum, definitely I need to be careful about my incision on the uterus, because the lower segment would be stretched and I would want to avoid the incision too low, and also the bladder flap, because there is a increased chance of bladder injury as well. So I need to make sure that my incision is higher up. And once the incision is done, then the head, if it is not impacted, then what I can do is I will be slowly introducing my hand below the baby's head and then flex. That is the main important thing. I flex the baby's head and then take through the lateral flexion. Obviously, I need to be very gentle because there is always an increased incidence of extension and extension of the lateral angles. However, if it is an impacted head, I have a couple of procedures which we can do. Of course, it depends upon the experience of the surgeon doing. So the first thing is the push method. In the push method, it is very, very important to make sure that the midwife or the probably a doctor, whoever is doing, has to be experienced. And here the mother's position, the legs would be in a semi-lithotomy position, and they have to be pushing the baby's head, but making sure that not that the pressure is only at one point. And when they push, the operating surgeon actually flexes the head and take it away, but take it above. But the problem with this is definitely one thing is concerns regarding fetal trauma, because we are putting the pressure at one point. That is the one thing. Second thing, while we are taking, probably if it is not lateral flexion, there is always a chances of extension. And the third thing is increased risk of infections. However, if we do not want to do that, then is the pull method or the reverse breath extraction, where I have to put my hands in the upper uterine segment, hold the fetal limbs and take the fetal limbs and make the back anterior and deliver the fetal head. Obviously, for this also, when we are taking out the baby's head, we need to be making sure the shoulder part especially, there could be lateral extension. And definitely this needs somebody who is experienced surgeon can do that. However, the third method could be Patwardhan's method. Patwardhan's we do, for example, we cannot feel the baby's fetal limbs, baby's limbs. Then we can do the reverse. Then we can do the Patwardhan's, where we deliver the shoulder, then the limbs, then the head. However, again, we have to be very careful and experienced, because if the shoulders are coming, then the operating surgeon should know how to do it. With all this, if during any of these procedures, we might need extension of the incision. So either we can go inverted T or the J shape, so that to avoid the lateral angles. However, all these things would definitely have concerns regarding the fetal trauma and the maternal trauma, like traumatic PPH and also the atonic PPH and also the infections for the baby. And once the baby is delivered, definitely the placenta need to be delivered and paired cardboard gas samples to be done. Third stage, active management of labor to be done. So I think this is the second stage of labor. Cesarean section at full dilatation is going to be very tricky. So that is the reason the importance of seniors being present to be done. And things which we shouldn't be doing is applying one single blade or trying to, multiple people pushing the baby's head. Those things we really need to be avoiding. And we need to make sure that everybody involved in the care should be calm and composed, and the proper teamwork and the communication to be done as well. And one thing which I wanted to also tell is there is a newer thing like medical devices which we could use. Obviously, there are no complete studies, randomized studies based on this, but there are two devices which are generally used. One is the fetal disimpacting system, where the silicone bulb would be put below the baby's head, and it would be raised with increased, you will inflate that with water so that the baby's head get elevated. And there is something called sea snorkel, where there is a tube which would be put with a vacuum ports. So once the pressure is given, the vacuum tries to elevate the fetal head. However, these are all in very initial stages and there is no randomized controlled studies. So that's how I'm going to manage the intra period. And
okay, now you have managed the case, the babies with the pediatrician, and all the necessary steps have been taken. So how will you go with the clinical governance part of this?
Yes. So the clinical governance part would be definitely I would want to document everything from pre-procedure to post-procedure, documentation is very vital, and then debriefing the patient with a duty of candor, what exactly happened and what we did, and debriefing the involved team, and also datex. The incident reporting to be done if the cesarean section was done at full dilatation and if there was a PPH more than 1,500 ml. Obviously, these are the most important clinical governance things we need to be looking into. But if we do have increased cases in our unit about second stage cesarean section, we need to look into the audit because we need to see our measure the practice which we need to be doing. And also about a bit about the postpartum period, I would want to comment, because once we shift to the post-op period, we need to make sure that a couple of things are taken care, especially she would be at a high risk of infection because of the manipulation. So we need to provide her with a broad spectrum antibiotics after ruling out the allergy. And definitely, if there was a PPH, obviously the need for blood transfusion to be assessed. And also we need to make sure that early mobilization and hydration and looking into her risk for VTE, if at all, if she needs a VTE prophylaxis, we need to look into the, we need to make sure that her risk of bleeding is reduced, and then we can start the low molecular weight heparin. Till then, we can give her the mechanical devices. And also breastfeeding support if she is willing to breastfeed the baby and if the baby is healthy as well. Yeah. And also counseling about the future pregnancies before she leaves, so that we can tell her that what exactly happened, and probably, especially if there is an extensions like inverted T at the J-shaped incisions, we know that next should be a repeat elective cesarean section. So we need to counsel her for the same and providing her with the information leaflets as well. Yeah.
Okay.
Yeah, I think we finished exactly on time, Aisha. That was allowed.
Yes.
Okay, yes, Aisha, how was it?
Yeah, yeah. You have covered most of the points. It was very structured, and one thing which I want to say is that you could have added 1 centimeter, one sentence saying that the instrumental delivery cannot be done here. Okay, then that's why you have to go for CS at full dilatation. Why? Then you can give justification. It is minus.
Yeah. Yeah, I don't know. I remember telling that it was 1 centimeter above spine, so I
Yes,
wouldn't.
you have told about that, but you can just
okay.
add
Yeah.
that
So
instrumental
specifically
delivery.
telling
Yes.
that I would definitely go for CS, not
Yes, yes,
yes. Of course, I didn't speak about instrumental delivery at all because
Yeah.
it was not on this one. Yeah.
Then rest of the patient safety points, you have covered everything. Again, regarding the post-operative period, I think you just, because you just ended at the cesarean section, could have continued there itself about the post-operative period. It just came after the clinical governance. That's okay, because we do not know what question they might ask. It could be post-operative period too, or here it was only clinical governance. So you can just come back and you can even answer. That's not an issue. Otherwise, overall well-performed station.
Okay, Sha. Thank you. So let's quickly talk about what we had done. So guys, second stage cesarean section could be a very, very, very normal and an important task, because I always try to use my hand movements to show how to do, because that's how I do. So I don't know, probably that could give an idea to the examiner. If you feel it is too much, you can avoid doing that. And very important, do not forget the team and informed consent, and very important, surgical safety checklist. You need not say the components, but a bit of it. And always think, what would you do when you shift the patient? So that's what I was actually thinking and trying to answer about the incision, because skin to skin, you need to be speaking actually at times. And bladder flap, I didn't take much of time. I just said that I would be taking the incision above. And if they specifically ask, how are you going to prevent the bladder injury? You need to say that you would be taking the incision above and you need to push down the bladder. Remember, the bladder would be very edematous, so you need to be very, very careful. And this is important. There are two things. One thing is impacted fetal head. The other one is normal, like the baby is there. It is not impacted as of now. How would you take up? So remember, flexing the head is very important. If you cannot take out the baby without flexing, if you actually think of how you do cesarean section. So that's important. People tend to forget. Disengagement, tocolytics, yes, if it is required, but remember the risk of PPH. Push and pull method, all of you know. Always try to explain a bit pros and cons of it. And pull method, when would you use? And Patwardhan's, when would be used? And extension as well. And medical devices, they are there, but there is no randomized study. So it's a good idea if you remember. But if you do not remember, the examiner is going to ask you, tell me the couple of devices. If you know, is there any method? Okay. And then this slide talks about the gist, okay? Techniques of prevention, like you can manually vaginal disimpaction or the fetal pillow, which I mentioned, or the techniques for the management, which we just discussed right now, okay? And then clinical governance, 4Ds, documentation, debriefing, the team debriefing the patient, datex, and obviously audit only if number of cases are increased, okay? So guys, the tips and tricks of the structured discussion again, probably see, sometimes they could ask you a lot of questions. Sometimes they stop with one question. So actually, like if they ask you one question, it should be pre-op, intro, post-op. Or if you think that like you can give a pause, if the examiner doesn't have a question, you can go on. That's the best way to deal. Try justifying, try covering the things. Whatever you talk about a procedure, for example, push method, pull method. What is it? Where they do? What are the problems? And if you can prevent them. But here, it is inevitable. It can happen. But still, how can you minimize the risk, right? And obviously, if the next question was post-op management, I would have, my mind that was there, like, okay, I could talk about clinical and clinical governance issues. So that's the reason I didn't cover post-op. But I realized that they are not going to ask me about the clinical after the clinical governance. So I took an opportunity because I had a time to finish the post-op as well, okay? So I think there is no black and white rules for this, but you have to make sure that you cover the task as a whole and probably justify and let the examiner speak, look into the examiner's eyes, what he's looking at, whether he wants to interfere, whether he has any other questions. Otherwise, I think structured discussions, especially in MRCPI OSCE, quite easy, quite straightforward. If you cover everything, they are not going to ask you much of a question. Hope this was helpful. Thank you, guys. Thank you so much. And Aisha, thank you so much. Thank you so much for joining. Thank you, everyone. Take care and God bless. And next session, it would be on antenatal care. So do not miss. It would be by Dr. Tazeen. Thank you, guys. Thank you and take care.